Welcome. Again, let me be the third in a long line of people to welcome you to your first day of school, as my kids affectionately call it. Welcome to this journey, this daunting and exciting journey that you all are beginning. It's a fabulous really privilege for us to be able to be here at the beginning with you. I always remember my first day of actual school at medical school, and I think most physicians do. And it's a special moment, and I hope you remember it in a very special way. You're getting an introduction to the way we think, and the we being a very broad, diverse, collective we. You've heard from esteemed folks in the departments of human genetics, internal medicine, pathology, and we all think slightly differently. We all approach problems differently, and it's important for you to get a sense that that you will have to develop your own way of approaching illness and disease, but be able to understand all different approaches as part of medical school. The title of this talk might seem a bit odd to you: medical decision-making, uncertainty, and the value of uncertainty, getting comfortable with uncertainty. And I would say that is a common theme that runs among all practitioners, all scientists, all people who work in the community. There is uncertainty everywhere in how we work with patients. And the important thing is to not run from it, but to embrace it and to become a problem solver, to figure out how can we deal with it and still make decisions in that context. That really is the purpose of the course that we're introducing to you today. Medical decision-making and evidence-based medicine becomes a thread that you will see interwoven among many of your different experiences throughout the next 3 years. So the end of patients and populations isn't the end of medical decision-making, evidence-based medicine, biostatistics, epidemiology. You will see these concepts come back over and over again. We're going to get very intentional with how you learn in the longitudinal cases around this concept. Next year, you'll see me again with all my cadre of faculty, colleagues that work on this with you. You'll see us again in the longitudinal case series next year. You'll see us in the wards and the clerkships and the clinics as well, as we try to really build these skills among you as you build a foundation and apply it in the setting. So right now your toolbox is empty. And by the end of these 4 years, we hope that you have a full toolbox of different options on how to deal with it. That really is the purpose: toolbox of choices and toolbox of skills. You've heard about many esteemed folks in the last couple of hours, people that shape our way of thinking. You've heard from Woody Allen. You've heard from Gregor Mendel. I would also say that you've probably heard from my colleagues who are far more esteemed than I am and are considered pioneers and leaders in the field of medicine, Dr. Galerder and Dr. Abrams. I've got more obscure heroes. I use pop culture to try and understand different aspects of medicine. And so this classic American movie, how many people know this movie? Right? Men in Black. It's now, unfortunately, it's a classic. When I started teaching this course, it was right out there. Men in Black 2 had just been released. So that shows you how old it is. Now it's probably considered to be on the American Movie Classics channel, when I know that I'm getting old. And what I'm going to play for you is a scene to give you an idea of why this course exists. So I'm going to set the scene for you, if you don't recognize it. Agent K, Tommy Lee Jones, is sitting with Will Smith, the character played by Will Smith, who has not yet been recruited into the force of these agents. But he has seen a lot of things already that just kind of blow his mind, that he never knew existed. And this is the recruiting speech that is Tommy Lee Jones is giving to try and place what Will Smith saw into context.
Humans, for the most part, don't have a clue. They don't want one or need one either. They're happy. They think they have a good bead on things.
But why the big secret? People are smart. They can handle it.
If a person is smart, People are dumb, panicky, dangerous animals, and you know it. 1,500 years ago, everybody knew the Earth was the center of the universe. 500 years ago, everybody knew the Earth was flat, and 15 minutes ago, you knew that people were alone on this planet.
Imagine what you'll know tomorrow.
Imagine what you will know tomorrow. So what happened is that obviously Will Smith had seen things that were aliens on this planet living normal lives, and he couldn't process this. And this became part of kind of the paradigm shift of different things that we hold to be true. Medicine is no exception to that rule. Knowledge shifts, it evolves. We have to be able, it's as important that you know what exists now as you have skills to figure out what will exist tomorrow. That's what this course is about. Let me start with a little history to give you an idea of how knowledge shifts. This is what scientists think as we create new knowledge. So this is another giant, a giant in the field of epidemiology, Pierre Louis. He was a French physician, and he introduced a method that he called the method of observation, or the numeric method. This concept is critical because, as I mentioned, knowledge shifts and we have to still have conclusions. Most people at that time were basing their conceptual models of health and disease based on their individual experiences with patients. And Pierre Louis, Dr. Louis, got us to think about collective data, aggregate patient data. And he did it in a field that was considered to be standard of care back then, and that was the concept of bloodletting. So back then, this is in the 1800s, humors, leech therapy, bloodletting, these were the key aspects of how we explain disease. You either had warm humors, cold humors. If you had too much hot, moist diseases manifested by febrile illnesses, manifested by arthritic inflammatory conditions, then what you needed to do was get the heat out. And the way that we would do that was through bloodletting. As you can see in this old artistic rendering, there is bloodletting that's going on here, and it's just pouring onto the floor. A little infection control problem. But back then, remember, infections wasn't really even a concept that could be carried. So Pierre Louis, this was the standard of care, and Pierre Louis was skeptical. He was skeptical based on some observations he had that some patients weren't really doing that well despite bloodletting. That skepticism is really the gateway to being systematic. The questioning, and we're going to hear about questioning over and over again. I want you to think about that being a core skill that he exuded at that time. And so what he decided to do was to study the data systematically. So he created a record of patients that he observed that were bled for fevers. And it was stratified by the day of the first bloodletting. Each one of these entries is an individual patient. Each individual patient was recorded for the duration of their illness and the number of bleedings that were required. Now, he didn't do a randomized control trial. We're going to talk about randomization and controlled clinical trials next year. This was observation, so he was seeing what physicians were doing at the time. And some were bled on day 1 after they developed their fever. Some were bled on day 9. And he would record his observations. He found a striking finding. What he found through this table was that those patients who were bled early in their condition did worse than those who were bled later or never bled at all. In other words, the standard of care, which was bloodletting, which people would do day 1, you presented to your physician with fever, you would get bloodlet at that time, fairly immediately. Those that were done early did worse. They died at a higher rate, they had more prolonged days of their fever, and they had many more complications. He was systematically collecting this data. And the numbers, actually, if you look at the previous table, the numbers were 44% mortality if you got bled early versus 25% if you bled late. He calculated these and talked to people. What do you think the response of the community was to this? No one believed it. No one thought this was a valid way of actually making conclusions about the effects of therapy. This was so heretical that he was quickly ostracized in the community of physicians. There was a small segment of people, though, that bought what he was doing. And they raised a second question, which is, well, maybe it wasn't that the bleeding early was the problem, but that those patients who survived to be bled late or bled not at all were just healthier individuals. And that's why they did better. They actually asked a very sophisticated question. If you dig into the history, you'll find that this concept is captured in conversations and letters that were exchanged between other physicians and Dr. Louis. That's the concept that you will hear from Dr. Gruber called confounding. So they raised the question of confounding very early on. It's that maybe the treatment wasn't the problem, maybe there's something else that is explaining the difference in the outcomes between those that got treated early and those that got treated later, not at all. So Pierre Louis did a second phase. He actually did another study where he stratified not only by day of bloodletting, but he also captured the severity of the disease and compared how severe patients were affected if they got bled early versus late. And he found that there was actually no difference in the severity of the disease, and yet those that were bled later or not at all did fine. So it wasn't, that's how he came back, but by that time people had tuned out, called him crazy, and moved on. But that was the 1800s, right? Core things that we hold dear and then get questioned. That doesn't happen now. Well, let me tell you a story about the CAST study. So when I was in medical school, a long time ago, the standard of care for what we would call ventricular arrhythmias that happen as a result of a myocardial infarction. What does that long phrase mean? That means that you have an MI, a heart attack, you're hospitalized, they put you on a monitor, they look at your monitor, and then all of a sudden, in the middle of the night, your heart goes fast. You have a ventricular tachycardic episode where your heart is running at 180 or 200 beats per minute, and then it stops. You actually don't have any symptoms, you're just sitting there, but your heart's irritated. It's inflamed and it's irritated and it's not conducting impulses appropriately. What we used to do then, the standard of care back then, was to give them a class 1 antiarrhythmic. You'll learn about this, especially as you go through your cardiovascular block next year. But that was the standard of care. We'd stop the rhythm. And that was done all the time. When I was in medical school, that is exactly what we would jump to. And then someone said, well, let's figure out if this is actually effective or not. And they did what was called the CAST trial, the Cardiac Arrhythmia Suppression Trial. And they basically said, we're going to randomly allocate those who have these arrhythmias to either get this intravenous flecainide, encainide, procainamide, or they're not. And we're going to see how they do. Well, what they found was stunning. Those that received the IV lidocaine, procainamide, flecainide, encainide, did worse than those that didn't. Did worse not just had a longer hospitalization, did worse not just that they had another myocardial infarction while they were in the hospital, they died. They died at a higher rate. Now keep in mind, by doing that study, we're not just documenting that we were harming patients in that study. We had been harming patients for 30, 40 years because of a lack of systematic approach to the evaluation of therapeutics. We had been doing that for a while. But of course that was the 80s, right? 80s were a crazy time, crazy hair, crazy clothes. No one was really thinking about things that much. We were kind of carefree and living in the Reagan era. But unfortunately, we continue to do this. So let me tell you a story about the Hearst Trial and women's health. In the 90s and in the early aspects of the last decade, when women hit menopause and had symptoms of vasomotor instability, hot flashes, had higher rates of myocardial infarctions, had dyslipidemia, their cholesterols were all over the place, started getting osteoporosis. The standard of therapy to help attenuate those symptoms and to really attenuate the risk of the development of future problems was to give women hormone replacement therapy. Estrogen replacement therapy if you did not have a uterus, estrogen plus progesterone replacement therapy if you did have a uterus. We did this all the time. And we actually we were touting the benefits of this, saying not only is this going to make you feel better, but actually that we have good data to support that you will have a lower rate of heart attacks. Your lipids will be better, your bone density will increase, and the whole thing about breast cancer seems to be a wash. It won't increase your risk, it won't decrease your risk. Of course, we were doing those studies based on what we called observational studies. That's the purpose of this course this month. Observational studies, you get women and you see those that happen to be on hormone replacement therapy and you follow them and see if they're going to get a heart attack, skeletal bone fracture. And those that aren't, who are also postmenopausal but not on hormone replacement therapy, you follow them as well. And you see whether they are going to get a heart attack or skeletal bone fracture. And the answer was that those that were on hormone replacement therapies did much better. They had lower rates of heart attacks. And so we said this was standard of care. And it really did achieve standard of care. Almost all physicians were doing this. Until some started saying, well, maybe what we need to do is a systematic study, a prospective controlled clinical trial, where we take those observations and we say, you know what I'm going to do? I'm going to take women and create a study where we'll take women and we'll randomly allocate them to getting hormone replacement therapy or not. And let's see whether this happens if we do it moving forward rather than looking backwards. That was the Hearst study and the Women's Health Initiative. Two phenomenally important historical studies. And unfortunately, what it showed was that the use of estrogen replacement therapy in women for postmenopausal symptoms led to higher rates of cardiovascular events, higher rates of heart attacks, higher rates of stroke, higher rates of cardiovascular complications, higher mortality rates in the first 2 years that didn't go away until 2 years after. So we were causing more harm than good, especially around cardiovascular outcomes. And the things that we were using to talk to patients about convincing them to go on this were actually based on lower quality studies, observational studies, as opposed to controlled clinical trials. I was one of those clinicians who would strongly counsel women to be on hormone replacement therapy. We all were, but we didn't have really good data to support what we were doing. Boy, this is a downer, right? I'm telling you all of these things, these terrible examples of how prospective studies controvert observational studies. The percentage of studies that are out there that are well done, prospective studies, that can really inform what we do, a really small number. Observational studies are the cornerstone, the foundation to how we generate hypothesis, and the vast majority of the decisions that we make in the clinical setting are based on observational studies. I'll start out by saying that. We still have to make decisions, and we have to operate based on the best available evidence. When we start talking about controlled clinical trials next year, you'll realize that it's actually a small percentage. It's not a lot. But when we can do them, and they're done well, we must pay attention to them. And what you'll learn during this course over the next 3 years is why we have a hierarchy of studies, and why that hierarchy contributes to the uncertainty that we wrestle with. There's an article that I put in your syllabus that I think I'd like you to read. Not that I think, I would like you to read, because it's just a thought piece on what it takes to put an ugly fact through the heart of a beautiful hypothesis. Sometimes our conceptual models are eloquent. We have fabulous data from in vitro studies, sometimes fabulous data from in vivo studies. It makes sense. The cascade of hormonal interactions, the cascade of the genetic interdependencies with risk, and how we can actually track that at a mutation level. They all make sense at a basic science level. But sometimes we also need to do the clinical study to figure out if there's other stuff going on that may prevent that hypothesis from manifesting in as simple and an elegant way as we'd like it to. So this raises the concept of clinical and translational and health services research, which are fundamentally important as complementary to basic science foundational research. You are going to be exposed to all of that, as I mentioned at Family Day on Sunday. It really is critical that you see the breadth, because it doesn't really matter if we know what to do if we can't do it in the actual clinical setting. So that will be part of how you evolve in this course. It leads me to a big picture understanding of what our course objectives are. Yes?
Just a quick question. Was the observational approach also the issue in the CAST study?
So good question. Yes, there were a number of observational studies, but there weren't a lot. But there certainly were a lot of small observational studies that were done in the 60s and 70s that had led to us implementing type 1 antiarrhythmics, class 1 antiarrhythmics in that care. We rarely do anything based on just an in vitro sort of theoretical study. We really do test it, but we didn't do it in a standardized, rigorous way. Let me tell you, the science of doing controlled clinical trials has evolved dramatically because of studies like the CAST. We probably didn't know how to do nearly as high quality a controlled clinical trial back then as we do now. Now that science has evolved dramatically. Yes?
Just real quick, when you do an observational study, you have to be comparing it to some baseline, comparing it to like a national statistic, or what is the comparison?
Right. So the question is when you do an observational study, you usually have to be comparing it to a baseline rate or a control group that is similarly made up. And so doesn't that add validity to the study? And the answer is yes, absolutely it does. But when you do an observational study, keep in mind that you, as the experimental designer, and we're going to get into this over the course of the month, we have no control over why people are in the intervention group or not. That happens. We have no control over why people may have a risk factor or not have a risk factor. So as such, there may be confounders that are either obvious or hidden that we cannot account for because of the fundamental nature of an observational study. The only way you can account for that is to start from scratch and randomly allocate people to one or the other, hoping that those potential confounders assort themselves randomly and equally among the two groups, and therefore, when you see the result, the only thing you could use to make the explanation of the difference between the two groups is the difference in the treatment or the difference in the exposure. That's the fundamental concept of why there is this hierarchy. I can tell you there are a lot of things that are wrong with controlled clinical trials as well, and we're going to get to that next year. One more question, and then I'm going to move on.
Yeah, well, I understand why a controlled clinical trial would be superior, but since most of treatment in life isn't putting people in groups and treating them equally, wouldn't the observational study support that somehow it kind of worked out that people were getting better because they had these respects?
So it's an interesting question. You're raising the question is, let me rephrase the question. Isn't observational studies more like real life than controlled clinical trials? And the answer is, yeah, it's more like real life. But in real life, there is so much noise that you have very little control of figuring out why something is happening. And so what we're trying to do with an experimental study is actually not only demonstrate that there's an effect, but understand whether our conceptual model that we walked in with, the research hypothesis, as you'll hear Dr. Gruber talk about, is the reason why we can explain the difference between the two, and then build on that to do the next study. When you do observational studies, you are struggling with the why. You may be able to see what happens, but you don't know why necessarily it happened. And that's what we need to know when we're helping our patients make decisions. When I'm sitting there counseling a patient about hormone replacement therapy, I'm not just saying you need to do this. I'm saying here's why we think this is a reasonable option. We need to know what's the strength and the evidence behind that why. Great question. So think about this. This is going to be a thread, again, and you're not going to end it this month. It's going to be going through the rest of your career. But it sets up why we have this course. It's to understand, appreciate, and begin to develop the tools that handle this uncertain world within which medical facts, attitudes, and decisions reside. It's also to understand, for you to understand, that skills development in this domain requires continuous application over time. It's not just in a single session. It's going to happen over time. We're going to be forcing you to do this in order to build these skills. And then finally, if the only thing we get you to do is to ask well-constructed questions, as you heard from Dr. Galerder, as you heard from Dr. Abrams, we will have gone a long way to making you part of this profession where new knowledge and new applications need constantly to be generated. A few housekeeping things, just want to make sure that you're aware of. As stated in the syllabus, assignments are the way that we do things in medical decision making. We don't have weekly quizzes. We have weekly sometimes bi-weekly assignments. There are 4 during the course of the month today. They're all available using the assignments tool on C-Tools. You'll figure it out. It's fairly straightforward. Basically, you're going to be doing assignments and bringing them with you to small group sessions where you will be discussing the answers with each other with a faculty facilitator. And then you'll be turning in that assignment at that time. You can work on the assignments. You have to work on them in advance. You can work on them by yourself. You can work on them in study groups. You can do peer things at a distance, whatever you want to do. The most important thing, we're treating you like adults. If you walk in and your assignment sheet is blank and you fill it in during the course of the small group, we'll never know. But at the end of the day, we're going to hold you accountable to the assignments, because on the final exam, it's all going to be drawn from the material and the concepts that are there. It behooves you to work through the problems, even if they're completely wrong when you walk into your small groups. No one is grading these. It's just mainly to help you figure out what we're trying to get you to do. Oh, sorry. Attendance is 20%, and the final exam is half of your grade. Another sort of resource you may want to consider is this JAMA Evidence, User's Guide to the Medical Literature. This is a manual. Don't get the essentials, get the manual if you want to get it. It's completely optional, strongly recommended. It's a great book to take you through the next 4 years and beyond. If you don't want to spend any money on it, you don't have to, because we have it online. If you go to the databases, and we'll talk about this in your computer sessions later in the month, but you can just go to this URL, search JAMA Evidence under database, and you'll find this book. I will reference passages from that book in the syllabus. You'll see a table which tells you some readings that might help supplement your understanding of this. And we'll be talking about this throughout the course of your next 3 years as well. Finally, another resource that we have that we started last year and this year as well. You all met Dr. Perkis, the gentleman with the blue tie and the blue shirt and the green tie yesterday, who oversees our whole online evaluation program. He has also taught statistics fairly extensively in the undergraduate years. He's available as a resource for us, for all of you. If you're struggling with this, if you're not getting a concept, he is available to meet with you anytime that you can set that up with him. He has an email address that you see here, and he's also crafting office hours, 2 half days during the course of this month, towards the end of this course, so to give you a chance to kind of work through it. But if you're still struggling on the 3rd week or 4th week of this course, he has office hours during these 2 half days. Just email him and set up an appointment during those 2 half days. He'll meet with you anytime beforehand as well if you'd like, but that's when he's blocking off big chunks of time. That course, it correlates with your computer sessions that we have as well. So you'll have time protected to be able to meet with him if you need to. So for today and for Monday, so I'm stating some learning objectives that will happen today and for Monday's lecture. So these 2 lectures are tied. Tomorrow you're going to get Dr. Gruber's lecture, as I'll explain. But the learning objectives are as follows, as you see there. At the end of this time, we really hope that you'll be able to summarize how new medical knowledge is created and applied, that you'll be able to describe how common diagnostic testing, and we're going to start talking about diagnostic testing, can lead to uncertainty in diagnostic reasoning. Sometimes the tests we give create more problems than they solve. And we're going to try and figure out from a numerical standpoint and a conceptual standpoint why that may be the case. And to also be able to summarize how uncertainty in diagnostic reasoning interacts with trust that our patients place in us as part of this process, and how we can mitigate that by good communication. So we're going to tackle all 3 of these concepts. A few other housekeeping things just to give you an idea of how our course is organized. We have 4 discrete skill sets that we're talking about, and you'll see this diagram over the next 3 years. Asking good questions, acquiring the information from sound, valid resources, appraising the information for its validity, and applying it in patient care decision-making. The asking and acquiring requires us to do some hands-on skills. You got to know how to ask a question. You got to know where to go. You also need to know where to go here at Michigan. Those of you that are new to this environment, we have a wealth of resources that are available. So we have some computer sessions, an optional one this Friday, tomorrow afternoon, completely optional. I'll explain it in a second. And then one other mandatory computer session later on in the month. It gives you it's a kind of a stepping stone. We're going to do a lot of this, more computer sessions over and over with higher and higher levels of resources over the course of 3 years. Just a little bit about the optional computer session tomorrow so you understand the logistics. Outside the door, there is a sign-up sheet. You can sign up if you would like to come. You need to sign up if you would like to come tomorrow. Don't come tomorrow if you haven't signed up. Do it right after our lecture today when you go and get lunch. Please do it then, because the sign-up sheets will be out there for maybe about 15-20 minutes. Basically, it's mainly for people who want a refresher or who are new to this environment. There's an overview that we'll give you that'll be hands-on on how to search our electronic books, our electronic journals, and some basic Medline searching. We assume that you all have done Medline, but maybe you haven't used our version of PubMed or our version of Ovid. We have two different tools. This is a good way to kind of get an overview. It's about a 50-minute hands-on computer session. We also have online demo modules that you can do instead. There's a handout that is attached in C-Tools to the computer session. You can just click on. We have a series of what we call screencasts that we have created, which just are kind of video movies that will show you how to click on different things so you know where things are. So you can do that as well. The key is whether you come to the session tomorrow or not, there is an assignment 1 that's due at your next computer session, the one on the 19th, 22nd, or 23rd, depending on where you're assigned. So that assignment is still due towards the end of the month, even if you come or not come to the computer session at the beginning of the month, tomorrow. All right? Any questions about the optional computer session? Great. Sign-up sheet is outside. You can do that after the lecture today. Then we have a second thread that will weave through both this course and the rest of your term. This is the appraise component. How do I know that the information I'm doing is valid, that I'm seeing is valid? How do I assess that? That's really a core component of the biostatistics and clinical epidemiology part of our course. And that is what Dr. Gruber will present an overview of this particular block. So he will be lecturing tomorrow. He'll be lecturing on Monday and Tuesday. And then you will have a small group session where you'll bring an assignment to that on August 11th, next Thursday. All these assignments have been posted, so you'll be able to see it. They'll be posted as of noon today. So you'll be able to see it. All the articles to read and the assignment template to fill out will all be posted. And then the final thread is this application thread, which is really about diagnostic reasoning. And we'll start that in just a second. But that will be part of our lectures starting now and Monday, and then especially on the 15th. And you will have a separate small group session, 2 small group sessions, both on the 16th and on the 24th to tackle these different concepts. And there's a lot of concepts to tackle, from Bayes probabilistic reasoning to sensitivity and specificity to using likelihood ratios, all stuff, some that may be new, some that may not be new, but you'll be applying it in actual clinical problem settings. Any questions about this cycle? This is how it unfolds during the course of the month. So just like any good storyteller, we're going to start, or storytelling, any good concept that gets highlighted by stories, we're going to start with the story. And we're going to start with the tale of the Odyssey. How many of you have read the Odyssey? This is not the Odyssey we're talking about. We're talking about a Honda Odyssey. So here's the case. I'm going to tell you a case. And I'll tell you why I'm telling you this case in a minute. There was a 1998 Honda Odyssey that had about 68,000 miles on it. No significant past maintenance history. And the Odyssey presented with a buzzer problem. Now I'm telling you, this is my Odyssey. This is my car. Let me tell you a little bit more about this problem. When I was driving it, even when all the doors and the trunks were closed, the door ajar buzzer would sometimes come on. Now, you got to put yourself back into 1998. Those of you, how many of you rode in a minivan? Yeah, you all must have rode in a minivan. The minivans in 1998 were fairly rudimentary. I mean, they were good, but they weren't like they are now. I mean, right now I got one with like 4 DVD players and wireless headphones for my kids, and I can still, listen to my sports radio while they're watching Harry Potter in the back. It's great. My Odyssey back then, the biggest thing we got it for is that we could click on our clicker and the door would just open. That was cool. Because if you had a town and country at that time, you had to pull and you had a kid in, and you had some groceries here, and you're trying to open the door and shove the kid in and then put the eggs on the ground without breaking it. It was a nightmare. So having this was really great, but it created electronic control that sometimes malfunctioned. And this was the malfunction. It had to have a door ajar buzzer that was triggered by the clicker, triggered by some sort of thing that would close, and it was all electronic instead of just being more manual, triggered by a little latch. I'm not, you can tell by the way I'm describing it, I'm not nearly as fluent in mechanic speak as I am in medicine speak. This is exactly the reason why I'm bringing this to you, because I had a feeling that my patients, the way they feel when they come to me is very much like how I feel when I go to a mechanic. I have no idea what's going on with my car, but I'm just beholden to the expertise in this individual, and I'm just saying, fix it. Tell me how much it costs. Really? I have no idea why I should question that that's the amount that it should cost. But it seems like a lot. So I go to the mechanic with this problem, and like a good diagnostician, the mechanic asks follow-up questions, just like you will when you encounter your first patient. He said, what other things are going on? Are there any other things you're noticing about your car? And I had a couple. I was writing this down systematically. I said, yeah, there are a couple of things that I've noticed, and I don't know if they're related or not. You know, I'm just kind of mediocre in this. But sometimes the trunk latch, which I somehow thought might be related to a door ajar buzzer, sometimes the trunk latch was stuck in the past, but it's not now. And I got a notice in the mail just about a month ago that says that there's an active recall on this trunk latch. Now, it's not giving me a problem now, but back then it was. I'm wondering if these two things are related. And the second thing is, yeah, you know, a couple of years ago, there was a problem that I had with this car, and it had a little automatic side door control problem. I didn't have a problem with it, but I got a recall notice, and like a due diligent owner, I went in and got it replaced 2 years ago. So I told him I did all the things that I was supposed to do, and I got a new recall notice, and I got this trunk latch. Is it at all related to the door buzzer ajar? And so the question is, what would a mechanic do at that point? Well, what he would do is that he would generate what's called a differential diagnosis. Now, they don't call it a differential diagnosis. We in medicine call this a differential diagnosis. It's a series of possibilities with associated probabilities. You're going to get a chance to do that for the first time at some point soon. So it's not just what do you think's going on, but what's the order? What's most likely? What's least likely? We do this all the time. Patient comes to me, 30-year-old woman who in the middle of the winter comes to me with a sore throat, but it's been going on for 3 months. I'm generating a list. Is this a URI? Is this just a respiratory infection? Is it allergic? Is it because she's got reflux disease and that acid is what's burning? Does she have a tumor that's sitting there on her vocal cords that's causing this sore throat? All of those things are going in your mind. Certainly tumor and a common cold are not at the same level of probabilities, right? We hope not that they would be at the same level. So I'm running through these lists in my mind with associated probabilities. The mechanic is doing exactly the same thing. And this was his list. He said, this is classic trunk latch problem. It's on recall. This has got to be what it is. Now, you may want to think, you know, maybe the door ajar side door sensor is not sensing things properly, or maybe your side door isn't closing properly. Here, let me look here and see if there's any, like, cotton balls or Cheetos stuck in the door that's preventing it from closing, and he didn't find anything. He generated his list, but he really thought that the trunk latch defect was the big thing. So what did he do? He told me it was a trunk latch defect. He says it's under recall anyways. Let's fix it. Seems reasonable, you know, could be associated. I felt smarter because I brought that to his attention. I'm like, ooh, wow, this feels good. Maybe I'm right. And then what does he do? He replaces the trunk latch. He drives the car, drives it around. So he does it like a good diagnostician. He drives it around, you know, around the parking lot. No buzzer. Comes back and says, that is great. It's fixed. No charge. Wow, great. No charge, right? Under recall, so no charge. That feels really great. I'm going to ask you to now stop and turn to your neighbor, introduce yourself to your neighbor if you don't know your neighbor, and spend 2 minutes and come up with 3 different diagnostic reasoning deficits. What could be the potential problem with this mechanic's diagnostic reasoning now stating that it's fixed? Because guess what? It ain't fixed. And I'll tell you how it didn't happen. So think about what could be wrong. share some ideas. What are some potential problems in our beloved mechanic's reasoning? Yes?
Replacing the trunk latch fails to address the association between the door buzzer deactivating the open door buzzer.
Ah, okay. So you're asking a fundamental question, which is, should it go on if the trunk latch is open as well? And the answer is it actually does. So it's the same door buzzer that goes on when the trunk is open as when the side door is open as well. But you may be asking another question, or maybe not. I'll just clarify that, and then let's keep going and see if something else comes out. Yep.
I don't think he drove the car long enough to actually come to a conclusion that it's fixed. I mean, he drove around for like, maybe 10 minutes and just came to a conclusion that there's no problem.
So you're wondering, did he drive the car around long enough? You're assuming he drove it for 10 minutes. I'd say it's probably measured more in the order of seconds that he drove the car around the parking lot. But so if he didn't drive it around long enough, why is that a big deal?
You can't come to a conclusion that it's actually permanently fixed. The problem is gone. You can't come to a conclusion that it's...
Okay, so you're worried that the problem is not permanently fixed. It's gone right now, temporarily, but it may not be permanently fixed. Okay, good. Yeah.
It didn't come on every time anyway, so he only started it once, I guess.
So you're saying that the symptom was intermittent anyway.
Yeah.
And so that was an important thing from the history, that it's not always on. Holy cow, if it was always on, I'd have a migraine headache driving there. It would come on and off. And so maybe just the period driving around the parking lot was when it was off. And so did it actually improve? Yes?
I think what the first person was going towards was that maybe the trunk latch wasn't the cause of the buzzer problem, but that they were both caused by some other factor.
Oh, I see.
And
so
determine that like one is exactly causing the other problem.
Okay, so maybe the trunk latch and the door buzzer are actually two associated phenomenon with something else that's fundamentally wrong with it, and maybe it was just an association. Good. So that's kind of getting at the confounding issue we're talking about. Okay, sorry, I misinterpreted what you had said before, but that sounds right. Okay.
I don't think he incorporated all of the information that you presented him into his decision.
Okay. So what information is missing?
The fact that turning off the automatic sliding side door control turns off the buzzer seems like it should be a tip-off, but the most obvious and apparent solution has to do with the fact that the latch is on recall. So that's the one thing.
Ah, so he did something. So let me just clarify what you said. The fact that I could turn off the automatic side door and just do it manually, and that would turn off the buzzer, should have triggered something else that wasn't related to the trunk latch. But he was doing what we would call convenient at that point, as opposed to maybe understanding truly. So he's still not paying attention to all the symptoms and all the story. Yeah?
It seems like he's ignoring the difference between the buzzer going off but not the light, where most of his hypotheses would be expected to either have both those things come on or neither, but for one but not the other to go, suggest something else.
You know a lot more about cars than I do, so I didn't even get into the whole light thing with him. But yes, that would have been a neat sort of associated clue to pull through. And by not tying those two together, was he really just sort of narrowly focusing his therapeutic intervention on something that seemed, as was pointed out before, convenient? One last one.
Driving slowly around a parking lot didn't adequately stress the vehicle to trigger a problem.
Okay, so maybe it wasn't just the amount of time that we drove around, but maybe there's some sort of mechanical jarring that would happen. Very insightful, because it would actually happen oftentimes. Remember I said it was intermittent? It would happen mainly when I would go over a speed bump and sort of jar it. Then all of a sudden I'd hear the ee in the back, going through the car. And so maybe there was some mechanical stress that needed to be placed on that. I'm not sure if I told him that it happened with speed bumps or not. He certainly didn't ask me. Now remember, this is sort of, I want you to keep thinking about the analogy of a patient and you, or a patient and a practitioner. Patients will often just tell us stuff that they think may be going on, and they'll sometimes try to be very helpful and give you things that may be associated that's going on. That's what I tried to do. I tried to say, look, I've got this recall. Is there any relevance to this recall? And boy, did this mechanic run with that. Our job as practitioners isn't to necessarily just run with that. It's to place that within the data of all the data that you're gathering, including data from the patient/car, or the data from
other diagnostic tests that might be there. You guys captured in very elegant way some of the classic diagnostic reasoning deficits we do as physicians. We sometimes do what's convenient. We fail to listen to all symptoms. We don't look at all the different possibilities. We do a lot of testing that are inadequate tests. And the other thing that I would say that this mechanic didn't do, he didn't really explain to me what his rationale and his reasoning was. This is what drives patients crazy, is when we don't communicate the rationale behind why we're ordering a new test or thinking what we're thinking. We may be wrong, but patients are very comfortable, more comfortable than you might think, with us being uncertain. Most of the studies on this have really demonstrated that. So those are the diagnostic reasoning deficits. For those of you that are interested in this, there's a fabulous article that Arthur Elstein and Alan Schwartz out of the University of Illinois in Chicago, who are considered to be really the pioneers in diagnostic medical decision-making and diagnostic reasoning. They've put out a very elegant article in the British Medical Journal. It's 9 years ago. It seems like a classic, but it still holds true today. So what happens next? Unfortunately, 1 hour after driving the minivan, this buzzer returns. Now imagine, put yourself in my shoes. I drove home from the dealership thinking, thank God it's done. And I drive into my driveway, and just as I hit the bump on my driveway, it goes off. After a few four-letter word epithets, what do I do next? I turned around and I went back. And you might be thinking, well, he's crazy, this mechanic, he's an idiot. Why is he going back to the same mechanic? Well, I felt like, our patients sometimes feel. I'm just going to go back. I don't have much of a choice. I didn't feel like I had a choice. Am I going to go through everything that it takes to go find a new mechanic through word of mouth, etc.? No, I'm just going to go back and talk to them, even though I was fundamentally questioning whether he had used appropriate diagnostic reasoning. Our patients come back. They may not be happy. And a lot of the studies show that our quality of our diagnostic reasoning and the amount of money that we're spending on unnecessary diagnostic tests continues to drive a sizable percentage of our healthcare costs. But yet our patients keep coming back. We have to get better. So does this mechanic. So, what does this have to do with clinical medicine? Well, I'm now going to pose you a clinical tale that you are now going to ruminate on between this lecture and our lecture on Monday. In clinical medicine, as I mentioned, we generate differential diagnosis with associated probabilities. Those probabilities are not fixed. They are what we are thinking at that time that are sometimes informed by data that we get, but they shift over time. There are ways to quantify the shifting in probability based on time that evolves, other tests and test results, or other data that comes to light. This story is the story of a 20-year-old woman who presents for genetic testing. Her mother had breast and ovarian cancer, and the assumption that we are going to make is that she likely has the BRCA gene. This is an autosomal dominant gene, as you will learn about, for those of you that have not encountered this before. And with the presence, and again, we're making an assumption here, so that you're going to have to indulge me with some of the assumptions we're going to make. We're assuming that because this 20-year-old woman presented and has a mother with breast and ovarian cancer, that she is positive for this mutation. Because she has this mutation, what is the likelihood, or that she might have this mutation, and that her mother definitely did? And the question is, if the mother definitely did have the mutation, what is the likelihood that the woman who is presenting to you in clinic has it? In other words, what's the likelihood that she's passed it on if it's autosomal dominant? And the answer is, should say that it's 50%. But how do we get to that? Well, some basics of some nomenclature that I'd ask you to think about that we'll explore more on Monday. When we write these things, we use the P, the word P, within parentheses, the event. P of X is the probability of event X. So whenever you see that, make sure that you know that's exactly what is being talked about. So the probability, the question we're asking, what is the probability that this woman has the BRCA mutation? And that's what we're trying to generate is the prior probability, based on clinician experience, what the patient is presenting with, their risk factors, previous testing, and in this case, genetic knowledge. So now, The answer to this question, based on our understanding of autosomal dominant inheritance, is that it's 50%. So we're starting out with this woman at 20 years old with the likelihood of having this, not having tested her, of 50%. But the story continues. Remember I said that probabilities shift. Now I'm going to ask you to suspend your concept of reality and jump into this time machine with me. And we're going to fast forward 55 years. Science hasn't changed in 55 years. That's the other belief that I'm going to ask you to suspend for now. But she's now 75 years old. And at the age of 75, she has not been diagnosed with breast or ovarian cancer. So she's gone 55 years not knowing whether she carries the mutation or not. But what we do know is that she does not, at this point, at age 75, nor in the previous 55 years, had any clinical manifestations of ovarian cancer or breast cancer. And the question now is, that first probability that we generated of 50%, that she has the BRCA mutation, is it still 50% now? Is her probability of carrying that mutation 50%? If it is, why? If it's not, I want you to think about, is it higher or lower than 50%? And I'm going to ask you to think about it from not only a logical standpoint, but from what you know about science. Come prepared on Monday to help us understand why you think it's either the same, higher, or lower. And we'll pick this up at that time. Alrighty? So, great introduction to medical decision making, and we'll see you on Monday. One thing, sorry, a logistical thing. What I'm going to